Good morning. I am Dr. Suhas Kulkarni, Associate Professor, Department of Pediatrics, D.Y. Patil Medical College, Kolhapur, India. I'll be talking on advances in pulmonary function testing in children. So this is the hospital where I work. So what is the need for this topic is the frequency of respiratory problems in the children 3 to 6 years is very high. And the trend previously we were treating as per the WHO protocol. The increased respiratory rate, we were taking it as a pneumonia. But now the trend has changed from the infectious diseases to the allergic and other diseases. So there is need to measure lung function in children. Measuring lung function in children above 5 to 6 years is done by spirometry, but it is not possible in the children who are less than 6 years. And only clinical history and examination is not very useful because in the pneumonia also there is a high grade fever, there may be high grade fever, increased respiratory rate, and in case of viral induced wheezing also sometimes because of the viral infection, high grade fever and wheezing can be there. Since the spirometry cannot be performed in children from 3 to 6 years because it requires forceful manuals, there are papers which say that it can be done, but still it is not feasible in the routine practice. So there is need for suitable method is there. So these children in 3 to 6 years, they present a different challenge that they cannot be subjected to sedation nor they can perform forceful manuals. So different techniques have been evolved. A few of them are interrupter resistance, impulse oscillometry, then plethysmography and inert gas washout technique. As I have been telling that the childhood asthma in low-income countries, this is a paper which indicates that whether we are treating these wheezing episodes or asthma as a pneumonia and not giving proper treatment. Similarly, this Lancet paper also tells about the that diagnosis of wheezing episode in preschool children, important advance should be made in the use of objective tools because you have to diagnose the condition objectively so that there should not be, there can be studies over there can be a proper treatment of that patient and proper follow-up. So the use of pulmonary function testing in general, we do for obstructive lesions like to diagnose wheezing episodes, in the restrictive lesions to diagnose interstitial pneumonia, neuromuscular diseases, or sometimes.
32 me dit déjà que je ne suis pas connecté, tu vois?
This or diffusion like we have seen in COVID.
Et maintenant, il va te connecter.
Non, il m'a envoyé un message ce matin comme quoi je n'étais pas connecté et que ça avait déjà commencé.
Excuse me? Unexplained dyspnea or hypoxemia, we do then respiratory muscle.
J'ai raté le speech de Patrick.
Then why we need objective measurement? Because distinct respiratory.
C'est un collègue avec qui je travaille. Patrick, je le connais depuis
Sorry
qu'il a
for the
15 ans.
interruption, Dr. Suhas, but Christine Manet, could you please mute your mic?
Should I go ahead?
Yes, enfin, je ne comprends pas moi.
Yeah.
Qu'est-ce que district?
So the distinct respiratory.
Christine, could you mute your mic, please?
So distinct respiratory noises are present where because if the parents at night, they observe some noises and in the morning when they go to the doctor, there may be discrepancy in that. And there are also intra-observer and inter-observer variations are there. And that is why we need objective measurements. So if you see the respiratory tract, previously we used to think that these wheezing or asthma, they are mainly large airways, but now it has been seen that even the small airways are involved. So it was seen that using if pulmonary function tests they are performed as per the guidelines, then the hospitalization rate in the children is decreased. Also, if the pulmonary function testing is not performed, then the asthma control is seen as controlled, but actually the patient has a residual some bronchospasm may be there. So it is always better to do the testing. The pulmonary function test, if we try to enumerate them, there are tidal breathing measurements, thoracoabdominal motion analysis, interrupter technique, the forced oscillation technique, multiple breath inert gas washout technique, body plethysmography, and exhaled nitric oxide. In that tidal breathing measurements, flow signals are measured at upper airways and volume signals are measured at chest wall. Ultimately, in all these measurements, we do flow measurement as well as volume measurement and sometimes pressure measurements to try to deduce the resistance, volume or flow. So two expiratory measurements are measured to analyze tidal breathing and can be done in infants. Then thoracoabdominal motion wall, we all know that indrawing of the chest is one of the important thing which we see when we are seeing the patients. And this respiratory distress, they cause indrawing. And to measure the magnitude of indrawing, we have thoracoabdominal motion wall analysis. Then interrupter technique, which has also come ahead to measure the resistance of airways. The airflow is suddenly obstructed at mouth and the pressure in the mouth, and it was observed that pressure in the mouth and alveolus becomes equal. So resistance is defined as calibrated pressure divided by airflow measured immediately before the interruption. So this is an interrupter technique. Then multiple breath inert gas washout technique is there. It is used to calculate ventilation distribution throughout the lungs and calculate the FRC. Can be performed in small children during tidal breathing. And inert gases used are nitrogen, argon, and it has also been used in this thing. So this, because it is important to calculate the FRC and residual volume. In body plethysmography, airway resistance is measured by calculating airflow and pressure. By body plethysmography, this is a more consistent way of getting all the volumes. The lung is considered as a tube attached to flexible parenchymal compartment, and the pressure in the alveolus is measured by sudden obstruction, again at the airflow in the mouth. Now, advantage of plethysmography, it measures the total gas volume, including areas which are not communicating with the central airways. And while gas dilution measures only those areas of lung in the direct communication with the apparatus. So those diseases where there is air trapping, plethysmography is a superior measure. And exhale nitric oxide came in a big way, and because the eosinophilic airway inflammation, but again, the enthusiasm has died down, but still it has a place to diagnose eosinophilic airway. Mainly, I'll be talking about forced oscillation techniques. So this is a simple non-invasive technique performed during tidal breathing. The relationship between pressure and flow is analyzed to find out impedance of the respiratory system. So this is the principle of impulse oscillometry system, where the sound waves are passed through the respiratory system and pressure and flow are measured on the time scale. So this is an impulse oscillometer system. This is a loudspeaker which generates the sound waves. This is a resistor. This is remote tachometer which converts it into electrical signals. This is the one. This is the transducer. So impulse oscillometry was formed in 1975. Michelson had developed this computer-driven system, and it was possible to measure multiple frequencies at the same time. So this was the advantage, and that is because previously forced oscillation technique was there, but at one time only one frequency could be analyzed. So this has saved a lot of time and can be used in children. It was found that the impulse oscillometry also correlates with spirometry, as has been seen in this paper by Ola Gibel. Here we can see how it works. This is an external pressure wave generator, produces artificial impulse shape, test signals of multi-frequency. Then this is a pneumotachograph. Then transducer measures airway opening pressure and airflow to calculate respiratory impedance, which is total impedance is called as ZRS, which is derived from pressure upon flow. And so in this way, you get the resistance, and it has two parts, resistance and reactance. So what IOS measures? Higher frequencies travel short distance up to larger airways, and lower frequencies travel deeper into the lungs. So this is a frequency dependence of the lung was found, and hence this system is very useful. So it measures respiratory impedance, resistance, and reactance, XRS. Also, it measures resonant frequency, where the two parts of reactance becomes, one is positive, one is negative, becomes 0, and reactance area are measured. So RRS, that is resistance of the airways, are at 5 Hertz. It means resistance at 5 Hertz frequency measures resistance of total airways. R at 20 Hertz resistance represents resistance of the larger airways. So in this way, we can have a total airway resistance. Then we can subtract the larger airway, and we can find the resistance in the smaller airways. So it's the same thing. The central airway obstruction leads to equally increased in the resistance, and peripheral airway obstruction increases resistance at low frequencies and resistance at high frequencies normal. So in this way, you can differentiate where is obstruction in the airways and how much is the obstruction, because it gives you a quantitative figure. XRS is a reactance, includes mass inertive forces of the moving air column. It has two parts, inertance and capacitance, and compliance of the lung. The reactance can be viewed as a rebound resistance, giving information about how much airways are distensible. So at low frequencies, the capacitive properties of small peripheral airways dominate. At higher frequencies, the inertive properties of large airways dominate. By convention, capacitive pressure is designated as negative and inertive positive. So because since there is a compliance, the elastance, it is in the negative form. And once the inertia is there, it is a positive. Like if you blow a balloon, initially there will be resistance and initial portion, but at some point it will start blowing. So in the similar fashion, initial frequencies, if you use, then it is more on the capacitive side, and later frequencies, it is more on the inertia side. Also, we measure the area and this thing. So American Thoracic Society has made a statement. According to that, ideal pulmonary function test should be applicable to any age, and monitoring should be possible, simple, easy to perform. So most of these criteria are followed by the impulse oscillometry system. So we performed a study to differentiate between wheezing episode and pneumonia in 3 to 6 years old children with clinical presentation and pulmonary function testing. We actually measured this impulse oscillometry in 106 children with the history of fever, cough, cold, and this thing, breathlessness. And the procedure was the child was sitting posture. The child holds the mouthpiece between his teeth and closes his mouth over it. Nose clip is applied. Child kept his hands over cheeks. The child was breathing normally, tidal breathing, and results are displayed. In this way, 3 measurements are taken, and then the child is given the in this COVID era, we are using the viral filters. Previously, we are not doing, but again, we have started doing. And this after giving a bronchodilator with the MDI spacer and this thing, we again measured. So this is a child performing the impulse oscillometry. And you can see here the initial resistance is shown in the percentage, which is 190, almost 200%. After giving the this R at 5 is around 197. So these are the normal values are available, and you can use them as a reference values. Also, then after giving the bronchodilator, the bed has become, so it gives a very practical and very objective record of what is happening with the child, how much bronchospasm was there, how much resistance was there, and how much it has improved. So this is one of the very useful tests. So in summary, the impulse oscillometer can be used to measure airway resistance in children in 3 to 6 years. The resistance at 5 Hertz helps in, and the change in resistance at 5 Hertz helps in identifying wheezing episodes among various respiratory disorders in children. Then the X at 5 also changes with bronchodilation, and the AX, and they are also useful. So the Marotta et al. Also concluded that impulse oscillometry was better than spirometry at discriminating between young children with and without wheezing on the basis of bronchodilator response. And measuring lung function is important before labeling children as asthma. So, so the recommendations which I would like to make are: objective pulmonary function test should be used to diagnose the wheezing episodes in children. The impulse oscillometry is an easy, child-friendly pulmonary function test which can be performed even in the OPD. It can also be performed in the bedside. Differentiation of wheezing episode from pneumonia will help in proper management of both the condition. In general, the pulmonary function testing should be used more and more, because in most of the other diseases, we are using a lot of tests. So here also, rather than just going for X-ray or a CT scan, if we perform pulmonary function testing in a proper way, it will be helpful in making the proper diagnosis and also the grading them. It is not only important to name the disease, it is also important to see at what level it is. So these tests, all the pulmonary function tests, are very useful and should be performed. And thank you very much for the patient listening. Thank you. These are the references which from which I have taken all this. Thank you very much.
Thank you, Dr. Suhas.